Hello and welcome to our press briefing from the Africa CDC. And we are coming to you as usual from the African Union Commission in Addis Ababa, Ethiopia. Now, this weekly briefing is really an engagement with the media by the Africa CDC in order for us to be able to share critical updates on the COVID-19 response activities on the continent, and particularly with the kind of support that is being lent to member states of the African Union. The briefing will also enable Dr. John to give us progress made in the implementation of Africa's COVID-19 vaccine strategy. So that's really the brief of why we reach out to you every Thursday. And thank you very much for being with us every Thursday at 11 a.m. My name is Wayne Musabayana, and I'm Head of Communication at the African Union. Now, today we are joined as usual by Dr. John Nkengasong. He is the Director of the Africa CDC. With him is Dr. Merawi Arago, and he is the Incident Manager for Ebola of the Africa CDC. When we come to the question and answer session, that is after the briefings by the two doctors, please use this WhatsApp number to send in your questions. So it is +251 9455 02310, +251 9455 02310. We also welcome your questions live on this platform, as well as questions that come in through the question and answer session. Well, it is time for me to bring in Dr. John, who is already on standby and is our host for this briefing. Dr. John, good morning, and you have the floor.
Thank you, Ryan, and welcome to this weekly briefing. As always, let me continue to really thank the press and media for their very important work and the support that they've lent in this incredible journey. And we find ourselves, as we'll discuss later, at a very critical junction with respect to the issue of distribution and access to vaccines to fight this pandemic. We'll come back to that later, but I wanted to upfront recognize the important work that the media continues to play a role they continue to play with us. As usual, I'll divide my presentations into three parts: the epidemiological update, and then what Africa CDC is doing, and then conclude with the vaccine situation. First of all, on the epidemiology, as of today, a total of 4.1 million COVID-19 cases have been reported across all 55 member states of Africa. This accounts for 3.4% of total cases globally. The total recovery remains high. About 90% of the cases have been, of people that were infected have recovered. However, our death rates continue to increase, with at least, as of today, 110,000 deaths across the continent. And this accounts for 4% of the deaths globally, with a case fatality ratio of 2. The following 5 countries represents or account for 65% of all cases. They include South Africa with 37% of the cases, or 1.5 million cases, Morocco 12%, or 492,000 cases, Tunisia 6%, 247,000 cases, Egypt 5%, with about 197,000 cases, and Ethiopia similarly 5%, representing 192,000 cases. As I indicated earlier, the global case fatality rate for the whole world is 2.2%, and for Africa it is 2.7%. The situation with the new variants remains the same, with 16 member states reporting the B117 variant, and I will not name them because we discussed them the last previous briefings. And if you want more information, we can always share that with you. And 17 other countries have reported the B1351 variant. And some of these countries have received a mixture of both variants. And as I said, it's needless to provide names here. You can always post them on our website. Now, let's look at the trends across. First of all, we look at the trends over the last 1 week, and then we look at the trends over the last 4 weeks. In terms of, and we call it the epidemiology week number 11, so that when we do our comparisons, we can actually understand what is going on. So if you compare last week, which was the epidemiological week 10, and this week, which is the epidemiological week 11, we have recorded as a continent about 70,000 new cases. And this represents a 3% decrease from the previous week. The highest proportion of new cases are coming from East Africa, and that represents about 33%. The other regions, that is the new cases by regions, include 26% in North Africa, 23% in Southern Africa, 14% in West Africa, and 3% in Central Africa. The following 5 countries are reporting the highest daily incident per million population: Seychelles, Botswana, Libya, Cape Verde, and Namibia. In terms of the deaths, as a continent, if you compare last week and this week, we recorded 2,089 new cases across the continent. And so this has not changed with respect to the last week, or epidemiological week number 10. We now look at the 4 weeks so that we understand a good picture of how this pandemic is evolving. That is the week between the 22nd of February and 21st of March. We have the following trends. In terms of new cases, we have observed a 1% average decrease in new cases in Africa each week. And by region, the numbers read as follows: 20% increase in East Africa, 4% increase in Central Africa, 3% increase in North Africa, 13% decrease in Africa, and 9% decrease in. So you see there's a mixture of 3 regions increasing, and then 2 regions continue to decrease. In terms of the breakdown by the most populous countries in Africa, we have Kenya reporting a 51% average increase, Ethiopia 21% average increase, Egypt 1% average increase, Nigeria 34% average decrease, DRC 12% average decrease, and South Africa 8% average decrease over the last 4 weeks. In terms of deaths, there have been an overall 7% average decrease in new deaths reported in Africa each week over the last 4 weeks. And if you break them down by the most populous countries, the distribution reads as follows: Kenya 57% average increase, Ethiopia 14% average decrease, DRC 10% average decrease, Nigeria increase, I beg your pardon, Nigeria 30% average decrease, South Africa 7% average decrease, and Egypt 5% average decrease. So let me now turn our attention to what Africa CDC is doing to support member states. First of all, as a continent, we are now very close to 40 million cumulative tests conducted since the start of this pandemic. That represents, if you compare last week and this week, there's a 5% increase in the number of tests. The total case positivity rate remains above 10%, about 10.3%. And with the PAC initiative, we're currently supplying, which is a partnership to accelerate COVID testing. We're currently supplying about 21.3 million tests. In terms of the antigen tests, last week, we continue to procure 4.6 million tests, and in the process of delivering 2.4 million tests. As of March 17, a total of 6.7 million antigen tests have been distributed to all 55 member states by Africa CDC. That is 6.7 million tests. Concerning the vaccination preparedness rollout, as we discussed a few weeks ago, Africa CDC has actually started a massive program to train vaccinators. And that program continues in many countries. 5 additional countries received that training rollout from Africa CDC last week. They include Botswana, Zambia, Malawi, Uganda, and Mozambique. A total of 500 participants, including clinicians, nurses, the expanded program on immunization managers from 20 countries have been trained so far on COVID-19 vaccination process. And again, it's a rolling on process. We continue to train more, and as we need so many vaccinators to achieve our common goals. Let me just conclude then by giving you an update on the vaccine situation. As of today, 28 member states have received their consignment of the COVID-19 vaccines from the COVAX facility. At this point, let me just pause here and say that all vaccines that come to the continent are Africa's vaccines. So there's really no difference between the COVAX vaccines and the AVAC vaccines. They're all trying to enable us to get to a 60% proportion. So this results in over 16 million doses of vaccines received so far on the continent. From that number, our statistics indicate that about 7 million, to be very specific, 7.2 million doses have been administered. So we are making tiny but very important steps in the right direction. A total of 18 member states have received vaccines outside of the COVAX facility through bilateral agreements, resulting in over 10 million doses received so far. With respect to AVAC, the African Vaccine Acquisition Task Team, 9 member states have received consignments of vaccines totaling 723,000 doses from the donation that we announced here a few weeks ago from the MTN telecom network. And again, just to refresh your memory, they donated $25 million to support the AVAC platform to acquire vaccines to support healthcare workers. The 9 countries that have received the vaccines include Gambia, Ghana, Guinea-Bissau, Liberia, Mauritania, Nigeria, Senegal, Sierra Leone, and Togo. So these are all vaccines from the AVAC platform. We will be, additional countries will be receiving their vaccines between now and over the weekend, and we'll complete that list and discuss it with you next week. And just to conclude, we are in the process, very, very close process of signing contracts or finalizing contracts with those 270 million doses of vaccines that President Ramaphosa, the president of South Africa, at that time, the rotating chair of the African Union, announced. So that will be very exciting, and we'll make sure that you all are briefed on that very important development. So I'll just conclude there and turn it over to Winnie. Winnie, please, back to you.
Thank you very much, John, for that very comprehensive briefing. And indeed, we are glad to note that the private-public partnership with MTN has started to deliver for the continent. At this point, let me just welcome everyone who's watching us, those who are joining us on this platform, those who are watching us on Facebook, on YouTube, on the African Union live stream, as well as the Twitter channel. Welcome and thank you for joining us for this briefing. It's time now for us to call in Dr. Merawi Arago, and he is the Incident Manager for Ebola, and he is with the Africa CDC. Good morning, Dr. Merawi. Please go ahead with your briefing.
Thank you, Madam Winnie. Good morning, colleagues. I will just give you epidemiological update on the current ongoing Ebola outbreak in 2 countries, as well as what Africa CDC has done and the new findings and concerns regarding to the resurgence of this outbreak in Guinea. To begin with the epidemiological update currently, as of today, 25th March, a total of 30 cases have been reported of this in 2 countries, DRC and Guinea. Of these, 15 has passed away with case fatality rate of 50%. 14 recoveries has been also reported, 6 in DRC and 8 in Guinea. In the DRC, a cumulative of 11 confirmed cases and 1 probable case with 6 deaths have been reported in the North Kivu province. Since the last briefing, there is no new case or deaths reported over the last 1 week. And it has been like 24 days since the last confirmed case reported in DR Congo. In the Republic of Guinea, a cumulative 18 cases with 9 deaths, with case fatality rate of 50% have been reported in 2 regions. And since the last brief, no new confirmed case or deaths has been reported. And it has been 21 days since the last confirmed case was reported in Guinea. In total, 8 individuals have recovered so far. From genetic sequencing, a genomic sequence done in Guinea of the viral extractors of positive cases shows then clearly the current outbreak is a result of resurgence of a strain that previously circulated in the West Africa region, the 2013-2016 disease outbreak in West Africa. This is really a concern, and it means that the virus can last longer than this, in survivors than it had been presumed before. So this is really a new concern that I wish to emphasize, and I'll get back to it. What Africa CDC has done so far is in line with our incident action plan and country response plan. Africa CDC supported or shipped thermal scanners and infrared thermometers to the Republic of Guinea to strengthen cross-border surveillance of these porous borders in Western region. And we will continue to support key response pillars in the outbreak response. So with regard to the genomic sequence finding, this really very shocking to find such a resurgence after 5 years of the outbreak. And a lot of questions has raised in the scientific community that we need to really address. So there is still an ongoing investigation and research on that area, including really what is the source, how does it survive this long, and so on. All those questions need to be addressed, and there is still ongoing discussion and research, the need for further research on this area. Thank you, Madam, and back to you.
Thank you very much. That was Dr. Merawi with a view of the situation regarding Ebola, which is affecting 2 of our member states. Now we jump straight into your questions, and the first one is coming from Judith Akolo. And Judith says, I work for the Kenya Broadcasting Corporation. My question is, now that a country like Kenya has reported the 2 variants from South Africa and from the United Kingdom, is the AstraZeneca vaccine effective on these new variants? And what should Kenya do in this case? These are questions for you, Dr. John.
So thank you, colleague from the Kenya Broadcasting Corporation. I have discussed this previously on this platform, and I hope I will try to clarify as much as possible. So if Kenya had sequenced, analyzed the virus some months ago, and then you see that the trends are increasing, that is of the variants are increasing, especially of the B135 variant, then it calls for concern. But if the analysis is a cross-sectional analysis where you take 20 samples, you analyze them, and you find the 2 variants there, then there's really no cause for concern. Again, it only suggests that we would need additional resources and efforts to continue to track the virus through surveillance to see if that variant is increasing over time. Otherwise, there's absolutely no need to not use the vaccine in Kenya. We don't think the situation in Kenya has evolved to a threshold past where the vaccine should not be used. There are countries within the Southern African region, like Zimbabwe, where that will be very, very true. True meaning that the variant has become the most dominant strain in that country. Like today, someone called me up in a country and said, look, they did 20 samples and then found out that the UK variant and the South African variant were there. There's not much you can infer from 20 samples. So that is what we are cautioning, that it has to be a very systematic analysis that you do that almost every month to see how the variant is evolving over time.
Thank you very much, Dr. John. Let's go online. And we have the first hand is Fatma Osman. Fatma, good morning. Please tell us your news agency and go ahead with your question. Good morning, Fatma. Your microphone is muted. Okay, I think it will take some time for us to get through to Fatma. Let's go to the next hand, and that is Sophie Mukwena of the South African Broadcasting Corporation. Good morning, Sophie.
Good morning. I just want to do a follow-up, almost similar to what my colleague from the arrival of the AstraZeneca doses from South Africa. Have you received the doses? And also in terms of distribution, how are you going to allocate the doses to different countries? And then the last question is on the strength of AstraZeneca. Clearly there are questions, and recently there were also strong arguments that the vaccine is not so efficient, or its efficacy on the virus, particularly the variant that was detected in South Africa. And now the question is, with Africa receiving majority of the AstraZeneca consignments, are you not worried that this will pose a problem for countries who have already administered those AstraZeneca vaccines that were received from COVAX? Are you not worried?
Thank you, Sophie. That's for Dr. John.
Yeah, thank you, Sophie, for that, for those two questions. First of all, I want to assure everyone that those vaccines that were secured from South Africa initially from the Serum Institute is the same source of vaccines that the COVAX has been supplying across Africa. So if they're all coming from the Serum Institute, I think that is one. The second thing I'd like to highlight is that all those vaccines that with South Africa had stopped using because of not because of safety, but because of the variant that predominates in South Africa, have now been acquired by the AVAC, which is the African Vaccine Acquisition Task Team. And those are the vaccines that I discussed earlier that are being distributed already to several countries, including Mauritius with 27,000 doses of vaccines, Senegal, 90,000 doses of vaccine, Guinea-Bissau, Gambia, 15,000, Sierra Leone, 42,000, Liberia, 27,000, Ghana, 165,000, Togo, 45,000, and Nigeria, 300,000. In the coming days, hopefully today or by the weekend, Guinea-Bissau will receive 12,000, South Sudan will receive 60,000, Malawi about 102,000, and Comoros received 6,000 doses of vaccines. So those vaccines continue to be completely distributed, and countries are extremely appreciative of that. Now, your second question on concerns with the variant. Remember, we have a mapping of what is going on the continent with respect to the variant through what we call the Africa CDC Pathogen Genomic Institute and NET initiative, which is really looking at trying to establish a network that will support countries either to move samples from countries that cannot sequence and understand which variants are circulating to reference sites, or strengthen the reference sites themselves. There are three levels. Here, there's three specialized labs, two of those in South Africa, one in Nigeria. And then there are regional labs, about 6 of them. And then below that are national labs that they all work together in a network together with the network we established together with the World Health Organization office in Brazzaville. So that is through that network that we continue to collect information and understand how these variants are moving across the continent. If you are interested in that details of that, next week we can devote some time to discuss which variants are circulating in which country and by what proportion. And as time you hear that a variant in country X is maybe a few samples that were sequenced, and that variant maybe came from a traveler that was that they pick up, and then they will characterize that country as having that variant. That has no epidemiological implications on how we should discuss it. Again, I know I'm repeating myself here, unless and until you have a proper surveillance system where you look at the specimens at a certain point, say last week, and then after 4 weeks, you analyze again those samples using a specific epidemiological method. You never know if that variant is a predominant or not predominant.
Thank you for that. The next question is very much related to that asked by Sophie. And this one is also coming from South Africa, and it's coming from Megan Lawrence from Network 24. And she says, which countries will receive South Africa's AstraZeneca vaccines that the African Union and the Africa CDC bought? And then she goes on further to say, can you disclose how much you paid for these vaccines?
So I just went through an exhaustive list of countries that have received the vaccines, and with the specific numbers and those that will receive the vaccines in the coming days with numbers. With respect to the pricing, again, that is not a secret, my colleagues. This is I'll leave that up to the Afri-Exim Bank, because they are the folks dealing with in this alliance that we have. That is the task force alliance that we have established that are dealing directly with the government of South Africa. So you can email them, and President Oramad and his team will be very happy to disclose that with you. But I tried not to provide information that I don't have control over, but it's not at all a secret.
All right, now we call on Coletta Wanjohi, and Coletta is with the FSN. Good morning, Coletta. Please go ahead with your question.
Good morning, Madam Wine. Can you hear me?
Yes, we can hear you very well. Please go ahead.
Okay, thank you. And thank you, Doctor, for the briefing. Just a bit of clarification on my colleague Sophie's question on the South African vaccines, AstraZeneca. There was an issue about the vaccines being tagged to an expiry date of April. How sure is the Africa CDC that the countries that are getting this will vaccinate before the April expiry date? Then secondly, we have issues we are seeing issues in terms of supply of the AstraZeneca. We understand that there are reports from India, with India telling the Serum Institute of India to ensure that the domestic supply is satisfied before the institute does major exports of the vaccine. Then we've also seen the European Union asking AstraZeneca to honor what it promised in terms of supply before giving out to other parts beyond the bloc. How does that affect the fact that we are expecting a consistent supply maybe to the African continent? Thank you.
Thank you, Coletta, for that for those very important questions. First of all, with respect to the South African vaccine, the expiring date was 13 of was initially labeled by Serum Institute as 13 of April. And if you recall, those numbers that I gave you, they are relatively smaller numbers. The largest, there being 300,000 vaccines for Nigeria. And in our estimate, Nigeria within 2 days or so should be able to use up 300,000 vaccines. Nigeria has received about 4 million vaccines from the COVAX facility, and I think using up 300,000 vaccines in 3 weeks, we should actually be very, very feasible and doable. Having said that, the Serum Institute did their own further analysis, and we have certification for this, and reported that the expiring date can actually be extended to 17th of July. And we have this on the record, which means that they did supplementary analysis to show that the active ingredients in the vaccines can go up to that. But we believe that these vaccines to be used on or before the 13th of April, which is still about 3 weeks since the vaccines were delivered. So I'm not so concerned with that. With respect to the two questions you raised about India putting a halt to the export of vaccines, as well as the European Union threatening to export vaccines, I think I must say that as a continent, I truly feel helpless, but remain hopeful that this situation is going to significantly impact our ability to fight this virus. We have gone through 2 waves of the virus, the first wave and the second wave. And I think it's fair to say that based on the statistics that I just shared this morning, that we are edging towards the 3rd wave. And without rapid access to vaccines, we will be challenged, continue to be challenged. Lives will be lost. Our economies will continue to struggle. So again, I really want to, I read the same headlines as you yourself, and I just have that sense of helplessness but remaining hopeful. Remain hopeful that the power of humanity will prevail, and we know and understand that this is a collective effort, that no part of the world, no country will be safe except everywhere, every country is safe with respect to this virus. The battle has to be a collective battle. It's just, I just have the sense of, is it? And it cannot be this, that we as humanity should be rise up above this and really implore the power of our own humanity, the strength of our own individual commitments to moral consciousness. Otherwise, we will be in this battle for a very long time. And I just don't know how else to characterize the situation, but it would definitely impact on our ability to continue our vaccination exercise.
Thank you very much, John. Rodney Muhumuza of the Associated Press had a very similar question, which you have just answered in terms of your concerns about what's happening with the Serum Institute of India. But then he goes on to have a second question. He says, would the director give us a more granular view of which African countries he is keeping an eye on in terms of their response generally, but also in terms of how quickly they are vaccinating their own people? Which countries specifically worry him the most and why?
So overall, when I look at the epidemiological trends on the continent, overall, I can give the continent a very good score because the patterns are very similar, where we tend to bend the curves almost the same time, and then the virus will escape, and then we also bend it down the same time. If you look at countries like South Africa, Kenya, Nigeria, they all have really done a remarkable job in bringing down the pandemic twice at very tough circumstances. But again, you see that the virus, you just cannot use public health measures alone to fight this virus. So overall, the continent has done pretty well, remarkably well in maintaining those public health measures and taking, I would call it courageous discussions, courageous measures I beg your pardon, to maintain the lockdown, the curfews, the restriction in movement. I think that has paid a lot, and you see that most countries go through that. If you take Nigeria, for just to put this in the context, if you look at Nigeria carefully, you see where it's a country of about 200 million. Their scenario could have been that of India or that of Brazil, but that is not the case. So I think we continue to see it do the right things and work with the Nigeria Institute, the Nigeria Centers for Disease Control to bend the curve. So there are so many countries out there that I can cite as good examples. Countries that are making tremendous progress with respect to vaccination, Morocco is really doing a great job. I mean, yesterday or 2 days ago, Professor Marofi, who has been on this platform to discuss the country situation with you, was on our platform to discuss the vaccination efforts in Morocco, which is very impressive. Rwanda is making remarkable progress. They probably have used all their vaccines that arrived already, and I'm sure many other countries. If that is also a topic of interest, of course, in the coming weeks, we should be able to analyze all countries, what they have received and what they have used. So I think that I'm very encouraged with the fact that the speed at which countries are picking up vaccines and using them. And we hope that that trend will remain. But what is key there is, as I said, using a common formula is we have to have vaccines plus vaccinations equals life saved. So you can, even with the best political intention, the best preparation to vaccinate in a country in Africa, if you do not have the vaccines, then you are really helpless. And that's why I feel that sense of helplessness that countries are geared up to go, but the vaccine market is extremely challenged. And again, I'm appealing to the power of humanity that we are in this together, and we shall either succeed together or we shall fail together.
All right, thank you. We take now a question that has come through our WhatsApp line. And this one is coming from Sarah Jerving with Devex. Sarah says, do you think that embassies should bring in vaccines for their own workers? Or is that problematic in terms of equity if foreign nationals get access to vaccines before citizens of the host countries?
Well, we are fighting this battle at very different points. If for safety reasons and security reasons, or how they characterize it, countries can support their own citizens wherever they are. I do not see anything wrong with that. I think but what we are not encouraging is where, despite our target, which is to say that we need to vaccinate 60% of our population to get rid of the pandemic, that anyone who has a vaccine tries to go into a country and then use that to build relationships. I think that is just not going to help us to get to our vaccine efforts. Every vaccinated person counts. But again, we've set up priorities in countries that we start with healthcare workers. We further vaccinate individuals who are at the front line, and we vaccinate the elderly and vaccinate those with underlying diseases. I mean, everybody should be trying to do this so that we achieve our 60% vaccination. So if anyone is my hero or a friend of Africa, you should really sit down with us and look at our target and say, how do we achieve our 60% threshold for immunization? We are not the only ones setting up that target. China plans to immunize about 80% of its population by next September. The United States and Europe, they're all trying to vaccinate 70 to 80% of their population, hopefully by the end of this year. So again, all partnerships are welcome. And we really would like to see that people rally around a master plan that has been developed by the African Union and endorsed by the head of states, rather than ignore that plan and then do individual isolated activities.
All right, it's time for us to say good morning to Julia Paravicini, and Julia is with the Reuters. Good morning, Julia. Please go ahead with your question.
Good morning, Winnie. Can you hear me?
I can hear you. Please go ahead.
Good morning, Dr. John. I am confused about the AVAT vaccines. Basically, you said at the beginning in your 3 doses that were part of the batch donated by MTN, but then you said that through AVAT, there was a purchase of South African vaccines that was handled by Africa Bank. So what is a bit purchase the vaccine
Hello, Dr. John. I don't know if you managed.
Because my understanding was that
Hello, Dr. John. I don't know if you managed to get that question.
No.
All right. Julia, your line seems to be bad. Perhaps you can send us your questions on WhatsApp, because we only caught a few words of what you were saying and did not get the rest. So please kindly use our WhatsApp number. All right, let's move on now to Paul Adepoju, who is with the Lancet, and he says, good morning, Dr. John. Several African countries are rolling out the Oxford AstraZeneca vaccine from the Serum Institute of India. Even though the WHO, the Africa CDC, and other stakeholders continue to describe the vaccine as safe, we are seeing subtle and major actions being taken as a result of the publication of stories around the vaccine. Now, what impact do you think the news surrounding the vaccine is having on vaccine hesitancy among Africans? This is one. Second question, how is vaccine misinformation different from other types of misinformation so far recorded in the current COVID-19 pandemic? And then lastly, what impact do you think the circumstances surrounding COVID-19 vaccines could have on immunization in general?
So, Paul, those are three very good questions. So with respect to the AstraZeneca vaccine, let me again restate this, that the vaccine is safe. And we've issued a statement to that effect, as well as the WHO and the European Medicine Agency, and which, as I described last week, we had a very thorough discussion on last week, Tuesday, across the continent, brought all the experts together with the European Medicine Agency to discuss that before issuing a statement. So we were very methodic, thoughtful, and careful with that statement. Is that going to improve the ability of the population to use the vaccines? Definitely, it has created some doubts around that. We have to be very honest with that. Can we improve that? Yes. Again, we implore all of us. We at Africa CDC are doing our utmost best to continue to engage the community and make sure that we transmit what that really means. The fact that European countries pause the use of that vaccine and have now resumed the use of that vaccine should also be a point that we emphasize in our daily conversations, that they have looked at that carefully, and they consider that the advisory that we issued with WHO and others is valid, and they are using those vaccines. We will continue in this journey of building trust with the community together with the media as much as we can. With rumors that we are hearing around vaccines are multiple, we expect that it will continue. But what we remain hopeful is that once the community recognizes that people that have been vaccinated have not been harmed from the vaccine, we believe that the pendulum will shift to the right, in the right direction, and many more people will use the vaccines once they become accessible. Human behavior is very difficult to predict, and we also know that we need a lot of that. We need to factor in a lot of human behavior in our response to pandemics or disease outbreaks. So the rumors that we are seeing with these vaccines that are available are not different from what we have heard from the origin of when the pandemic started. Remember that when the pandemic started, we heard things that related to the origin being 5G or 4G and others. So that subsequently went away, I believe, and then with time, other rumors will come up. We have to commit ourselves to not being the spreaders of false information. And it happens through social media a lot, where people receive information. You may actually read it and feel that it's tremendously ridiculous, but then what you do is that you share it through your networks or to another person in the spirit of either joking or making a mockery of that, but you've transmitted it, you've translated it, and then you don't know where it will end. So my call and appeal is that when we receive those very unreasonable assertions and information, do not forward it to the next person. Delete it, and that way we stop it. It's like we're all fighting to stop the spread of the virus. Let's also fight to stop the spread of these rumors. With respect to the effect on other vaccination programs, absolutely yes. There will be a serious effect on other vaccination programs across the world, for sure. But the bright spot is also there to highlight. We should remember that a country like Ethiopia did remarkably well during this pandemic by immunizing at least 12 million of its children in 1 year. So that explains, gives us hope that if we do the right thing and support countries, those immunization programs may be protected. And I think that the Ethiopian experience was really very good and is what we're sharing with everyone.
Thank you, John. Let's try Fatma again. Fatma, good morning. Hello, good morning, Fatma Osman. All right, we're still having problems, or rather Fatma seems to be having problems coming through to us. So let's take a question that has come through the question and answer section. And this time we say hello to Lawrence Caramel, who is with Le Monde. And Lawrence says, have countries like the DRC and Mali who stopped using AstraZeneca resumed their vaccination programs?
I mean, truly don't know the situation in DRC if they resume and Mali if they resume their vaccination program or not. But we will definitely follow up on that to ensure that we to understand what is going on in the country.
All right. So Julia has now come through on our WhatsApp platform, and she says, Dr. John, you said that 723,000 vaccine doses were distributed through AVAT from the MTN batch. But then she says you also went on to say that AVAT purchased through Afreximbank vaccines from South Africa. The question then is, why did AVAT have to purchase vaccines from South Africa if the vaccines were donated by MTN? Did MTN purchase the vaccines through Afreximbank? Those are the questions that Julia wanted to put through to you.
Yes, I think, Julia, your story or the narrative is very aligned. The AVAC is a grouping of the Afreximbank, the AMSP, that is the African Medical Supply Platform, the African Union Commission, and the Africa CDC, and some member states like that were appointed to be part of AVAC. So that is, consider it to be a consortium of people. So it's not Afreximbank purchasing the vaccines, it is through AVAC. Now, the MTN made the donation to Africa CDC to support AVAC. So that pot of money all goes into supporting the AVAC process. So it's not separate. It's not Afri-Exim as such. Afri-Exim is acting on behalf of AVAC to get those vaccines. So what we did as a CDC is to get those, the donation from MTN straight out to an account within the Afri-Exim and allow them to get the vaccine. So that is how it works. So it's not the Afri-Exim purchasing, doing that separate purchase, and then the MTN doing a separate purchase. I hope that helps.
Thank you for that clarification. Bonisile Makubu from the Times of Eswatini. She says, if the vaccine certificates eventually come, will there be a need to mention which vaccine a person has taken? And will this not create a gap, since some vaccines seem to be looked down upon based on their efficacy?
That is a very good question. First of all, we hope our position as a Africa CDC, and speaking on behalf of the African Union Commission, is that you can only impose a vaccine certificate for travel if the vaccines are available and are accessible and affordable for everybody to get. So at that point, the question becomes, where the vaccines are available, why have you not gotten your vaccines so that you can have your vaccination card? So I think that is a very separate conversation that we are taking a very clear position on. And having said that, the discussion at the appropriate time, the discussion will define the modalities of who gets the vaccine, what type of vaccines is it, and then the duration of that certificate. But to the best of my recollection, that discussion has not started. But those are key questions that would need to be discussed when that conversation begins.
All right. Sarah Jerving has a question for Dr. Merawi. Now, she's making a follow-up on your presentation earlier, Dr. Merawi, and she wants to know what it means for how Ebola survivors will be monitored moving forward. So she says, there are so many people in West Africa that were positive in the 2014 to 2016 outbreak. How will countries manage this large-scale monitoring with limited resources? And then lastly, how will survivors be monitored if they are no longer living in the West Africa region?
Thank you, Sarah, for that, for those important questions. Yes, you are right. This is still, as I said, it is under still investigation to further clarify how this virus survived all this long. And is this really a question of, is there an ongoing unrecognized chain of infection, or is this really a persistent chronic infection in an individual that can really jump into full-blown outbreak? This is still a question. With regard to survivors and monitoring of survivors, yes, we do have protocols to follow them. And ideally, the previous record showed that it is up to like 500, it is months, like 1.5 years shedding the virus from the survivor. But this one is very unique, that it is like after 5, 6, 7 years that we got this one. So what does it entails in monitoring and following up is how can we really protect such kind of transmission without stigmatization of an individual, the survivor. I think the survivors really pass through a very hard situation, very hard pressure from the community with the pains they have been, and all sorts of, they need all sorts of support for their challenges, including social, as well as even the pain. Some survivors also manifest pains up to 2 years, some even extend up to 4 years. So with that challenge, having this one is also increase real concern and for a stigma. So what is that we need to do is we need to educate the community to have this unprotected sex is still a high risk, that we need to be really very conscious, and they have to have really good decision making in their engagement on this process. So that is one thing. The other one is we need also, as a public health agencies, we need also to have a mechanism to track and monitor and support these survivors all for a pretty prolonged time than the previous exercises we saw in the DRC and West Africa. So this is a long conversation that we need to have with regard to what kind of systems that we need to put in place, and what are the therapeutics that can really help to at least to make this shedding a bit shorter. And so this, a lot of things are going, but it's really provokes so many deep discussions that we need to have moving forward from the individual perspective, from the public health agencies perspective, and in general, the health system strengthening perspective. Thank you.
Thank you. We come back to Dr. John with a second question from Judith Akolo, who is with the Kenya Broadcasting Corporation. Now, she starts by noting that there are vaccine manufacturers that are being very aggressive in terms of marketing their vaccines in some countries. So her questions are two. The first one is, does the Africa CDC approve of this? And the second one is, what ought to be the right channel?
So these are very good questions. Africa CDC has published guidance, and you can go to our website and see this on how vaccines should be introduced on the continent. And there are three pathways or scenarios, as we call them. Scenario number one is vaccines that have been approved by the World Health Organization or issued an emergency authorization use. Scenario number two is the countries that, or vaccines that have actually received an emergency authorization use from a recognized national regulatory authority, like the European Medicine Agency, the United States FDA, and others. Scenario number three are vaccines that do not meet the scenario 1 and 2. That is, they have not been approved or authorized by WHO, neither have they been authorized by the national regulatory authorities. We then have the African vaccine regulatory task team that can review that those vaccines. A case in question will be the Sputnik vaccine, which we have a team that is reviewing, team of experts that will review that and issue our own advice on that to member states. So we believe the reason I go to this extent is that we have a process in place that should be used by our respective member states, and that if we follow that process, then again, we are protecting our citizens and then making sure that we have a common approach and showing the unity of purpose during these very extremely challenging times. And it will also fast track the uptake of vaccines in the country. With respect to companies or individual manufacturers dealing with countries directly and very aggressively, my response to that is that is why AVAC has been established for member states. If you work through AVAC, you're going to have a common price for the member states as much as possible. The vaccine market is extremely challenged. And we heard this during this discussion, when Coletta asked the question about what India has just announced, that they will put a halt to exporting vaccines, and the European Union is also threatening the same, and other countries have been doing that. It only suggests that the best way for us as a continent to succeed is to work collectively and work through AVAC. The AVAC mechanism is supplementary to the COVAX. COVAX has set and they have been very clear with this, that they will supply us with 20% of our vaccine needs. That percentage may increase, but that is what we have been told, and we are very grateful for that. But if you square that with a 60% threshold that we are aspiring to get to, which we are not the only people trying to get to that level, that threshold, others are aspiring to get to higher levels, then we have to find a mechanism to bridge that gap and get to it. And the only way to do that is to work collectively through AVAC, the African Vaccine Acquisition Task Team. So again, my short answer to that would be that member states should work very closely with AVAC. AVAC is an AU mechanism that was set up by AU member states under the leadership of President Cyril Ramaphosa, and it should be used by all member states.
All right, thank you. We are now going on to our last set of questions for today, and they're coming from Lawrence Caramel. This is the second time to come to the platform today, so thank you very much, Lawrence. So he says, how many governments in Africa are refusing vaccination programs for their populations? And secondly, what can be the consequences for the continent?
Yeah, there are a few countries in Africa that have stated their position with respect to vaccines, and we regret that, and we remain hopeful that they will change their stance on that. We know that vaccines will be the game changer in our battle against COVID-19 pandemic. And there are about 4 or 5 countries that have taken that position, which of course differs with what we as a continental body are recommending. If you recall, at the start of this pandemic, we were very clear. We issued, we jointly developed a continental strategy that was underpinned by the need for us to coordinate our efforts, to cooperate, to collaborate, and to communicate. We were very clear, and as African Union, we expect that all member states will adhere to these principles, the core values that underpin our need to work as a people for our common survival. There's absolutely no way that the continent will get rid of COVID if some countries take a stand that is not informed by science and informed by good public health. And that has always been our position. And we remain hopeful that these countries will take a look at their situation and commit to this common cause, which is the cause of getting the virus out of our continent.
Thank you very much, Dr. John. It's time now for us to get your summaries, both yourself and Dr. Merawi. So perhaps let me start with Dr. Merawi. If you can just very quickly, in a minute or two, summarize those key messages that you feel are really very important for our audiences today.
Yeah, thank you, Madam. I think from the current finding, the current outbreak, what is the new lesson that we learned is this virus can survive and stay longer than expected. And we need to have more educational engagement, especially with modes of transmission and potential resurgence of disease outbreak from potential survivors. So as a message, I think what we need to educate the public in general is we need to be very supportive to those survivors while we are protecting. We are also knowing the sexual risk in general, but it doesn't mean that we need to really stigmatize those survivors. And also these casual contacts like handshaking and so on is not really a risk that people should take note of. Thank you.
All right, thank you, Dr. Merawi. Now we hear the final words from Dr. John, who is the director of the Africa CDC. Dr. John.
So thank you, Winnie. I think let me end with where I started with the vaccine situation, which is, it leaves me personally with a sense of helplessness But I remain hopeful that the power of humanity will prevail and that our collective consciousness will also prevail. I believe strongly that we should continue to be our neighbor's keeper. And the only way we do that is to exercise that strong sense of solidarity and coordination. And with the wisdom that, with the common wisdom that this virus will not be defeated anywhere, no matter how smart you are to vaccinate all your people, and the virus is still circulating in other parts of the world, especially in Africa with a population of 1.2 billion people. And that is extremely important for that wisdom to prevail. And I remain hopeful that that wisdom will prevail over time. There is absolutely no need for us as a world, as humanity, to go into a vaccine war in this pandemic. We'll all be losers. Thank you.
Very strong message there from the Director of the Africa CDC, Dr. John Nkengasong, bringing to an end our press briefing for today. So it is now my pleasure to just thank you again for having joined us, all colleagues from the media and from the communication sector. I think the challenge is out there for us to continue to communicating on this issue and to communicate correctly, as the Africa CDC always emphasizes. It will be for the benefit of all our audiences. Well, our press conference for today ends here. Let me thank Dr. John and Dr. Merawi, colleagues from the Africa CDC and the African Union who've been behind the scenes bringing this to us, as well as all of you again for having been with us for the past hour or so. Let's meet again next week on Thursday at the same time. Bye-bye for now.
Thank you.